Good morning, Butcho. Okay, settle down, settle down. Right, today we're tackling something, well, something that's basically the entire infrastructure of the human body. Our blood vessels. I want you to think of them like the plumbing, the highways, the wires, everything that keeps the lights on. If they go wrong, everything goes wrong. So yeah, it's a pretty important topic. Just look at this. Let it sink in. Vascular disorders are responsible for more morbidity and mortality than any other category of human disease. More than cancer, more than infections, more than anything. This, Butcho, is why today is not just about passing an exam. This is the bedrock of clinical medicine. You want to understand heart attacks, strokes, kidney failure? You have to understand this. This is the stuff you'll be dealing with every single day of your careers.
All right, so here's our roadmap for today. First, we'll look at the basics, the body's plumbing. Then, we'll see what happens when it breaks down. After that, we dive into the big bads, hypertension, the silent killer, and then the main culprit, atherosclerosis. Simple enough? Cello. Let's begin.
Okay, Section 1. Our body's plumbing system. The blueprint. Shallow. Let's start right at the beginning. I love this analogy. Think of the entire vascular system as the plumbing in a huge, complex building. You've got the main water lines, the smaller pipes going to each floor, and then the tiny taps in every room. Our body? Exactly the same principle.
No, have a look at this diagram. It shows you everything from the huge aorta down to the tiniest vessels. And what's amazing is they all share the same basic design, a three-layer sandwich, if you will. On the inside, touching the blood, you have the intima, super important, lined with endothelial cells. In the middle, you've got the muscle, the power, that's the media. And on the outside, a protective wrapper, the adventitia. That's it. Intima, media, adventitia. Got it? Simple, nah?
And this is where that design really makes sense. Look at the difference between arteries and veins. It's all about function. Arteries are getting blasted with high-pressure blood straight from the heart, right? So of course, their walls are thick and muscular to handle that force. Veins, totally different story. They're the low-pressure return system. Thinner walls, much wider, they're more like big floppy bags. And get this is a fantastic fact. At any given moment, about 2/3 of your entire blood volume is just chilling out in your veins. They're like the body's blood reservoir. Amazing.
So let's follow a drop of blood on its journey, eh? It gets pumped into the aorta, this huge elastic pipe that expands and snaps back. From there, it goes into the muscular arteries, which are like the regional highways, distributing the flow. And then we get to the most important part for blood pressure control, the arterioles. These are the traffic controllers, the taps. They can squeeze down or open up, and that's what really determines your blood pressure. After that, it's the capillaries for all the delivery and pickup business, and then the veins for the slow, lazy journey back home to the heart.
All right, so we know what a healthy pipe looks like. But what happens when it gets a crack, when it gets injured? This is where it gets really interesting. The body's response to vessel injury is very predictable, almost robotic. It's a stereotyped response. And here's the catch. Sometimes the fix is actually worse than the original problem.
You remember those endothelial cells lining the intima? I want you to think of them as the bouncers at a club. Normally, they're super chill. They keep things smooth, everyone's happy, no fights, no drama. But if you start causing trouble, with high blood pressure, smoking, too much bad cholesterol, these bouncers they get angry. They go from being peacekeepers to troublemakers. They become dysfunctional. They start promoting inflammation and clots instead of preventing them. And that, my friends, is where all the trouble begins.
So what's the result of this dysfunction? It's like a bad construction project. Step 1, the inner wall gets damaged. Step 2, a help signal goes out and smooth muscle cells from the media layer start migrating to the scene of the crime. They move into the intima where they don't belong. Step 3, once they're there, they just start multiplying like crazy. And step 4, they start laying down concrete and steel, extracellular matrix. What you're left with is this scar tissue, this neo-intima, that thickens the wall and starts blocking the pipe. The body tried to patch a hole, but it ended up narrowing the whole highway.
And that whole process we just talked about, that's the calling card of our first big villain, hypertension, the silent killer. Why silent? Because this damage can be happening inside a person for 10, 20 years with zero symptoms. It's like a slow, quiet earthquake, just relentlessly shaking the foundations of the body, the arteries, the heart, the kidneys, until one day, everything comes crashing down.
Okay, so what are the numbers? Clinically, we say hypertension is a sustained pressure of 130 systolic or 90 diastolic and above. But please, Butcho, burn this into your brains. There is no magic line. It's not like 129 is perfectly safe and 130 is disaster. It's a slope. It's a continuum. The higher the pressure, for longer, the more damage is being done. The official number is just a line in the sand for treatment.
So this is the crazy part. It's one of the most common diseases on the planet, and for 95% of people who have it, we have no idea what the single cause is. Look at the chart. We just call it essential or idiopathic hypertension, which is just a fancy way of saying we don't know. It's some messy combination of your genes, your diet, your stress, everything. Only that tiny little 5% sliver is caused by something specific we can point to, like a kidney problem.
So let's just pause and think about this physically. What happens to a tiny little garden hose if you hook it up to a fire hydrant and turn it on full blast for 20 years? It's not going to just sit there, is it? The walls have to react to that constant, relentless pressure. They have to change. And those changes, well, they have consequences.
And here's what those changes look like under the microscope. Two classic patterns. On the left, you've got hyaline arterial sclerosis. See how the wall is all thick and pink and kind of glassy? That's from plasma proteins literally being forced into the wall by the high pressure. It's super common. But now look at the right. This is hyperplastic arterial sclerosis. This is way more severe. The smooth muscle cells have gone crazy, multiplying and wrapping around the vessel in layers. Doesn't it look exactly like the layers of an onion? An onion skin appearance. When you see this, you know you're dealing with really, really bad malignant hypertension.
Okay, so all this thickening and stiffening we've been talking about falls under one big general category. It's called arteriosclerosis. Literally, it just means hardening of the arteries. Now, this is an umbrella term, so pay attention. It's not one specific disease, and it's super important you don't confuse it with our next topic.
So under this arteriosclerosis umbrella, you've got a few types. There's arteriolosclerosis. That's the one we just saw with hypertension in the small vessels. Then there's this weird one, Monkeberg's, which is just some calcium buildup that's usually not a big deal. You've got fibromuscular hyperplasia. But forget all those for a second. The fourth one, that's the one that matters. That's the main character of this whole story, atherosclerosis.
All right, Butcho. Deep breath, pencils down for a second. I need your full attention here. Because what we are about to discuss now, atherosclerosis, is probably the single most important pathological process you will learn about in this subject. This is the why behind most heart attacks. It's the why behind most strokes. It's the disease that you, as future doctors, will fight against every single day. So let's get into it.
So what is atherosclerosis, really? It's the buildup of this specific lesion called an atheroma, or what we commonly call a plaque. The best way to think about it is like gunk building up in a kitchen pipe. It's this raised lump inside the intima, and it's nasty stuff. It has a soft, fatty, lipid-filled core, mostly cholesterol, that's covered by a hard fibrous cap. And this thing grows and grows, blocking the pipe, and worse, it can break.
Okay, so the million-dollar question. Who gets this? Well, the risks fall into two buckets. The first bucket is stuff you're stuck with. Your genetics, your age, being male. Can't do anything about that. But then there's the second bucket, the modifiable risks. And this, Butcho, is where you come in as a doctor. This is where the magic happens. High cholesterol, hypertension, smoking, diabetes. This is the list of things we can actually fight. This column is where lives are saved.
And if you have to pick just one villain from that list, one public enemy number one, it's this. High LDL cholesterol, the so-called bad cholesterol. Let me be absolutely crystal clear on this. Even if you have perfect blood pressure, you don't smoke, you're not diabetic, if your LDL is high enough for long enough, that alone is sufficient to cause atherosclerosis. Full stop. It's that central to the whole story. Okay, so let's zoom out and see the whole story we've just told. You start with the perfectly smooth, healthy blood vessel, but then it gets attacked by these risk factors, high LDL, high blood pressure. This injures that delicate inner lining. The body panics and starts a healing process, but it's a flawed process. It's that intimal thickening we talked about. And when that process is fueled by tons of lipid and cholesterol, what you get is an atherosclerotic plaque. And just like that, a healthy vessel has become a ticking time bomb.
Whew, that was a lot, I know. But do you see the pattern? We've gone from simple, basic things like blood pressure and cholesterol all the way to complex, life-threatening diseases. It's a direct line. So I want to leave you with one final question. Not for an exam, but for you, for your life. Look back at that list of modifiable risks.
What is the one thing you can change or help someone else change, starting literally the moment you walk out of this lecture hall? Think about it. Thank you.
All right, everyone, settle down, settle down. Welcome. Today, we're going to do something a little different. We are going to become detectives, and we're going deep, deep inside our own arteries. We're going to uncover the inside story, the real story, of a condition that is a silent killer for so many people. Okay, let me ask you all a question. Simple one. What really causes a heart attack? Go on, think about it. Most of you will say, "Sir, it's a blockage," or "a blood clot." And yes, you're not wrong, but that's the final scene of the movie. That's the climax. We need to go back to the beginning to find out who the real villain of the story is. And here he is. The villain has a name. Atherosclerosis. I know. It's a bit of a tongue twister, Heina. But look at this definition carefully. It's a chronic. That means it's happening for a very long time, an inflammatory and a healing response. What does that mean? Basically, your artery gets a small injury and your body, like a good doctor, rushes in to fix it. The problem is this repair job, it goes completely haywire. It's a healing process gone bad. All right, so first step in our investigation, let's look at how this faulty repair job, this atherosclerosis, is the hidden mastermind behind all the big disasters, your heart attacks, your strokes. Okay, every good detective knows before you catch the criminal, you have to understand the circumstances. You have to profile the suspects. So what are the conditions that let this disease even start? These are what we call the risk factors. Let's line them up. So here are the usual suspects, the big gangsters everyone knows about. First, you have hypertension, high BP. Look at that, a massive 60% jump in risk. Then there's smoking. It literally doubles your chances of dying from heart disease. And not to be left behind, diabetes. Also doubles the risk of a heart attack. These are the big three, the main bad guys. But here is where the story gets interesting. A real twist. Look at this number, 20%. That means 1 out of every 5 heart attacks or strokes happens to people who don't have any of those big 3 risk factors. No high BP, no smoking, no diabetes. So what's going on? There must be a hidden player, an accomplice we haven't found yet. So what is it? The answer, my friends, is inflammation. Just read this quote. It's absolutely crucial. Inflammation isn't just something that happens at the end. No, it's there from day one, at every single stage. It's the silent partner in crime, pulling the strings from behind the scenes, from the very start to the very bitter end. So if inflammation is the hidden culprit, how do we find it? We look for its fingerprints in the blood. And one of the best markers is something called C-reactive protein, or CRP. Now look at this graph. It's telling you something very important. It doesn't matter what your other risks are. If your CRP is high, your risk is high. It's a powerful, independent clue that danger is brewing. Of course, it's never just one thing, is it? Atherosclerosis is a team sport for the bad guys. You've got other players involved, things like hyperhomocystinemia, metabolic syndrome, this really nasty, sticky cholesterol called lipoprotein A, or LPA. And then, of course, the things we control, or don't control, lack of exercise, and that classic type A personality, always stressed out. All of these things just add more fuel to the fire. All right, so we've profiled the suspects. Now for the main event. Let's look at the crime itself. How does a perfectly clean, smooth artery turn into a clogged, dangerous pipe? Let's break it down, step by step, the real pathophysiology. Okay, so the whole thing starts with something we call the response to injury hypothesis. It's simple, really. Step 1, something injures the delicate inner lining of your artery, the endothelium. This is the trigger. Immediately, a chain reaction begins. Bad cholesterol, your LDL, starts seeping into the wall. Then your body's immune system sounds the alarm. Your monocytes, a type of white blood cell, rush to the scene. Platelets also come sticking around. It's like a traffic jam and a construction site all in one, and it's happening inside this tiny artery. This diagram here shows you the whole story beautifully. See? It starts with that little injury. Then the monocytes squeeze into the artery wall. And once they're inside, they get hungry. They start eating up all that bad cholesterol, just gobbling it up. Meanwhile, smooth muscle cells also get called in. And this whole process, it doesn't happen overnight. It's a slow motion disaster, building up over years, even decades, to form this thing we call a plaque. Now, let's zoom in on these guys. Foam cells. You absolutely need to know this term. What are they? Well, remember those monocytes that went inside? They turn into macrophages, which are like the cleanup crew of the body. But here, they eat so much LDL cholesterol that they get fat and bloated. And under a microscope, they look, well, foamy. These foam cells are the very first building blocks of the plaque. They are the foundation of the whole problem. Okay, so that's the microscopic story, cell by cell. But what happens when you zoom out? What does this look like after 20, 30, 40 years of this silent construction project? Let's have a look at the final form of the plaque. And wow, look at this. This is the whole story in just 2 pictures. On the left, this is where it all begins. Little yellow lines called fatty streaks in a young person's aorta. They look pretty harmless, right? Now look to the right. This is the result. Decades later, it's a complete mess. These are huge, complicated plaques. Some of them are even breaking open. The difference is just shocking, isn't it? Now, please understand, this plaque is not just a simple blob of cholesterol. No, it's a very complex, organized structure. It has an anatomy. Look at this table. On top, you have a fibrous cap made of smooth muscle cells and collagen, trying to keep everything contained. Then you have the shoulder region, which is packed with all those inflammatory cells. And deep inside, that's the really nasty part, the necrotic core. It's basically a garbage dump of lipids, dead cells, and all sorts of gunk. Let's zoom in even more with a microscope. On the left, that's a cross-section of a coronary artery. And notice something interesting? The plaque is eccentric. It's growing on one side, pushing the opening to the other. Now look at the magnified view on the right. This is not a dead structure. It's buzzing with activity. You can see inflammation, you can see tiny new blood vessels trying to grow into it, and you see calcification. It's becoming hard, like a rock. This is a living, breathing, and very dangerous thing. Okay, so for years and years, these plaques are growing. But listen to me very carefully now. This is probably the most important point of the whole lecture. It's not just about how big the plaque is. The real danger, the life or death question, is how stable it is. This is where we get to the climax of our story. And here's the difference. You have 2 types of plaques. A stable plaque has a nice, thick, strong, fibrous cap. It's like a well-contained garbage dump. But then you have the vulnerable plaque. This one is the real killer. It has a very thin cap, a huge, soupy, lipid-rich core, and it's boiling with information. The best analogy? It's like a big pimple with a very thin skin, just ready to pop. So what happens when that pimple bursts? The thin cap tears open, and all that horrible, gunky stuff from the necrotic core spills out and touches the flowing blood. Now, this core material is what we call highly thromogenic. The second blood touches it, it thinks there's a huge injury. So what does it do? It clots instantly. A massive blood clot, a thrombus, forms right there, right on top of the ruptured plaque. And this image right here, this is the moment of crisis. This is the money shot, as they say. What you are looking at is an acute coronary thrombosis. That dark red mass is a fresh blood clot that has formed literally in minutes, completely blocking the artery. This is the heart attack. This is the stroke. This is the catastrophic event. So let's just recap the timeline. It's a story of 2 different clocks. You have the slow clock, ticking away for decades, as the plaque grows silently, without any symptoms. And then you have the fast clock, the one that starts when the plaque ruptures. And that one is measured in minutes. Decades of silent preparation, and then minutes to complete disaster. So if you walk out of this lecture remembering only one thing, I want it to be this. Please listen. The growth of the plaque, that is the long-term chronic problem, but the rupture of the plaque, that is the sudden, acute, and deadly event. One is the disease, the other is the heart attack itself. Which brings us to the final and very personal question for all of us. As we get older, the question isn't just if we are forming plaques, because most of us are. The real question, the life and death question is, are your plaques stable, or are they the vulnerable ticking time bombs just waiting to rupture? I want you to think about that. Good morning, everyone. Welcome. Today, we are going to take a very critical journey into the body's largest pipelines, our blood vessels. We'll explore what happens when these vital structures fail, leading to some of the most dramatic emergencies in all of medicine. This is a continuation of our deep dive into cardiovascular pathology. So, cello, let's begin. All right, my future doctors, here is our roadmap for today. We'll start with the structural failures, things like aneurysms and dissections. Then we'll move into the inflammatory process of vasculitis and how we classify it. And we'll finish up with a very interesting functional problem, hyperreactivity. Okay, let's dive straight into our first topic, aneurysms. Now, these are not just some simple swellings, okay? They are localized, abnormal dilations that represent a fundamental weakness in the vessel wall. You can think of it as a dangerous bulge. Here's the key funda you must remember. For it to be a true aneurysm, all three layers of the wall, the intima, media, and adventitia, all of them must be involved. This is not just a surface swelling, it's a fundamental weakness of the entire vessel wall, which makes it so prone to rupture. Now have a look at this specimen. This is a classic and frankly a frightening example of an abdominal aortic aneurysm, what we call a AAA. You can see the sheer scale of the dilation here. This is exactly what happens when the wall weakens, it balloons out, and then, catastrophically, it ruptures. And this chart, this brilliantly illustrates why size matters so much in our clinical practice. Just look how the risk jumps. It goes from just 1% per year at 4 to 5 centimeters to a terrifying 25% per year when it gets larger than 6 centimeters. This data tells us exactly when we have to intervene surgically. So the crucial point to take away is that while atherosclerosis is the big villain for abdominal aneurysms, you must remember the other causes. For aneurysms in the ascending aorta, for example, hypertension is the main culprit. And then, of course, we have genetic conditions, infections, and even some specific inflammatory diseases. And this is what a genetic cause looks like under the microscope. On the left, in a patient with Marfan syndrome, you can see the chaotic, fragmented elastic tissue. It's a complete mess. Now compare that to the neat, strong, organized layers of a healthy aorta on the right. You see, this structural defect is exactly what leads to the weakness. Let's move on and see how this builds to our next topic, aortic dissection. Now this is not a bulge, but a tear. It's a true medical emergency where high-pressure blood literally rips through the vessel wall itself. Here is the crime scene. That small tear you are seeing in the intima, the innermost layer, that's the entry point. Once that happens, the high-pressure blood from the aorta starts forcing its way into the wall, ripping the layers of the aorta apart from the inside. And under the microscope, this is what's happening. The blood, which you can see here in red, is creating a false channel, a hematoma, right inside the media. It is splitting the wall in two. It's an absolutely catastrophic structural failure. Now listen carefully. You must remember this for your exams and for your entire career. The location of the tear is everything. Type A involves the ascending aorta and is a surgical emergency because it can rupture straight into the heart sac. Type B is distal and can often be managed by aggressively controlling the blood pressure. This classification completely changes the management and the prognosis. Now we're going to shift gears. We're moving from these structural problems to an attack from within, vasculitis. This is where the body's own immune system gets confused and starts inflaming the walls of the blood vessels themselves. I want you to think of it as a three-step process. First, there's some kind of trigger, often it's immunologic. This leads to the second step, inflammation. And finally, that inflammation causes the third step, vessel damage, which can weaken the wall, cause clots, or narrow the vessel, starving the downstream tissues of blood. Now, vasculitis is not just one disease, but a whole family of them. It's a complex group, so to make sense of it all, we classify them based on the size of the vessel they prefer to attack. Large, medium, or small. It's a very logical system. So let's start large. This is giant cell arteritis. On the left, you see the clinical sign, a tender, inflamed temporal artery on an elderly patient's head. On the right, that's the pathology. You can see the granulomatous inflammation with giant cells. This is a classic large vessel vasculitis that we must diagnose quickly so we can give steroids and save the patient's sight. Here we have another large vessel vasculitis, Takayasu arteritis. Just look at the profound narrowing of the major arteries coming off the aorta. You can immediately understand why these patients, who are typically younger women, present with weak or even absent pulses in their arms. Now we are moving to the medium-sized vessels. Do you see how the entire lumen here is blocked by an inflammatory clot? This is Berger's disease, a terrible consequence that is almost exclusively seen in heavy smokers. This occlusion leads to severe pain and can even result in gangrene of the fingers and toes. And now we go down to the small vessels. This is granulomatosis with polyangiitis, or GPA. It's an ANCA-associated vasculitis. That's anti-neutrophils cytoplasmic antibody. And you can see these characteristic granulomas attacking the vessel wall. It typically affects the lungs and the kidneys. Finally, let's look at a different kind of problem altogether. It's not a weak-all and it's not inflammation. It's a functional issue of overreaction. We call this vascular hyperreactivity. The classic example here is Raynaud's phenomenon. This is a case of the vessels just clamping down way too hard and way too fast in response to cold or stress. This spasm restricts the blood flow and causes those classic red, white, and blue color changes in the fingers and toes. So the crucial point for you as a clinician is to distinguish between the two types. Is it the primary, benign form, which is quite common and not too serious? Or is it secondary to a more serious systemic disease like lupus or scleroderma, which can have much, much worse outcomes? To summarize our entire session, you can really think of these major diseases as failures of 3 different systems. Aneurysms are a failure of structure. Dissections are a failure of the wall's integrity. And vasculitis, that is a failure of the body's own immune regulation. Always, always connect the pathology back to the patient who is sitting right in front of you. Understanding these fundamental processes is the very first step to becoming a great physician who can not only diagnose, but also treat and heal. Well done today, everyone. Hello, everyone, and welcome back. We are continuing with Chapter 11 today, and we're jumping into a topic that you will see every single day in the wards, the pathology of blood vessels. Trust me, these conditions are so common here in India, so understanding them isn't just about passing your exams, it's about your entire career as a doctor. So, chalo, let's get started. Just think about that for a second. 1 lakh kilometers. That's enough to go around the planet more than 2 times. It's this unbelievable network that's keeping every single cell in your body alive. But what happens when this vital superhighway system starts to fail? Well, the consequences can be pretty serious. Let's start by looking at the body's drainage system. So, we are going to start with the veins, and for a very good reason. You are going to see venous diseases all the time, from the super common varicose veins that your patients will complain about to the really dangerous deep vein clots. Getting a good grip on this is absolutely essential for your clinical practice. Okay, that textbook definition sounds a bit heavy, right? Let's break it down. Just imagine the valves in your veins are like one-way doors. Their job is to stop blood from flowing backwards, because of gravity. But when there's too much pressure for too long, these valves get weak. Think of a rubber band that's been stretched one too many times. It just doesn't snap back. The doors don't close properly, blood starts to pool, and the vein swells up. And that, my friends, is a varicose vein. Simple as that. So you might be asking, what causes this high pressure in the first place? Well, as you can see, there are a few usual suspects. Standing for a long time, think of a surgeon in a long operation or a traffic policeman. Obesity, which adds a lot of extra pressure inside the abdomen. Pregnancy, which can physically press on the big veins. And of course, sometimes it just runs in the family. So when you're taking a patient's history, these are the questions you absolutely have to ask. Okay, now this slide is critical. This is a 5-star classic exam question, so please pay attention. A clot can form in any vein, but where it forms makes a world of difference. If it's in a superficial vein, close to the skin, yeah, it'll be painful and red, but it's very unlikely to travel. But a deep vein thrombosis, a DVT, that's a silent killer. Imagine a patient who just had surgery and is on bed rest. They might feel completely fine, but if a piece of that deep clot breaks off and travels to the lungs, it can cause a fatal pulmonary embolism. That is why you must always, always have a high index of suspicion for DVT. All right, so far we've been talking about problems with blood flow, blockages and bad valves. But what happens when the very structure of the blood vessels goes wrong? When the cells that make up the vessels themselves start to multiply out of control? Well, that's when we enter the world of vascular tumors. So let's start at the good end of the spectrum. Here we have something like this hemangioma. Basically, it's just a harmless little tangle of blood-filled vessels. You've probably seen these. They are the most common tumors in babies and children. Those little strawberry marks on a baby's skin? Most of the time, they just go away on their own. Usually, it's just a cosmetic thing, nothing to worry about. But in medicine, things are rarely just black and white, are they? Not all vascular tumors are so simple. Some of them fall into this gray area. They're not exactly benign, but they're not fully malignant either. These are what we call intermediate-grade tumors, and a classic example is Kaposi sarcoma. Now, Kaposi sarcoma is really fascinating. It's actually caused by a virus called HHV8. But here's the catch. The virus alone is not enough. The tumor's behavior depends completely on the patient's immune system. It's like the virus is the seed, but it needs the right soil to grow, and that soil is a weak immune system. You can see there are 4 different types, but they all have one thing in common, a compromised immune system. Whether it's from old age, transplant drugs, or most famously AIDS, a weak immune system lets this virus run wild. And this is what it looks like. This picture shows the classic signs of Kaposi sarcoma perfectly. You see these reddish, purple patches, plaques, and nodules on the skin. So if you're in the clinic and you see this on a patient, especially on their legs, your first thought must be Kaposi sarcoma. And what's your second thought? To check their immune status. All right, so we've seen the good and we've seen the in-between. Now let's move to the really bad end of the spectrum, the truly malignant vascular tumors, which are called angiosarcomas. Just take a look at the microscope slide here. Remember that nice, orderly hemangioma we saw earlier? Well, this is pure chaos. It's a complete mess. These are malignant cells growing wildly, and they aren't even forming proper blood vessels. They are extremely aggressive, they invade everything around them, and they spread early. And unfortunately, that means the prognosis is often very poor. Okay, so we've talked about all these problems, blockages, clots, tumors. But what happens when we as doctors step in to fix them? Well, as you're about to see, sometimes our solution can end up creating a whole new problem. Look at this. This is a modern miracle of medicine, really. A patient has a blocked artery in their heart. We go in with a balloon, open it up, and then we place a stent, this tiny little mesh tube, to keep it open. And look at that angiogram. The blood flow is restored beautifully. So problem solved, right? Well, not so fast. You see, the body is very smart, but sometimes it's too smart for its own good. It sees the stent and thinks, hey, foreign object, I need to heal this area and cover it up. So the smooth muscle cells in the vessel wall start to multiply and create new tissue all around the stent. This process is called intimal hyperplasia. And sometimes this healing response is so aggressive that it creates a brand new blockage inside the stent. We call this in-stent restenosis, and it's a huge challenge. The very fix becomes the new problem. Okay, we've covered a lot today. Before we wrap up, let's quickly summarize the absolute key points. If you remember nothing else, remember what's on this next slide. This is your high-yield summary for exams and for the words. Let's do a rapid fire. Varicose veins? It's all about faulty valves. DVT? The key is that high embolism risk. Hemangioma? Common and benign, nothing to worry about. Kaposi sarcoma? Think HHV8, and always check the patient's immune status. And finally, stent restenosis? That's the body's own healing response. Intimal hyperplasia gone wrong. This slide is perfect for your last-minute revision. So as you can see, the vascular system is this dynamic battlefield, a constant fight between pressure, flow, and cell growth. And as future doctors, your job is to understand these forces so you can intervene intelligently. That's all for today. Study hard, and I will see you in the next one.